Good morning, everyone. This is Dr. Rajesh. Which one? Start video. Good morning, everyone. Today we are going to discuss a topic called autoimmune pancreatitis. It's one of the common thing which we encounter these days and usually remains untouched. Basically, it's a form of pancreatitis which usually presents with the signs and symptoms of obstructive jaundice, sometimes with the pancreatic mass or without. On histology, we usually see the lymphoplasmacytic infiltrate and the fibrosis. And interesting enough, it dramatically responds to the steroids. There are different terms which are used for the same entity, like lymphoplasmacytic sclerosing pancreatitis, chronic sclerosing pancreatitis, non-alcoholic duct destructive pancreatitis, granulocyte epithelial lesion positive pancreatitis, idiopathic duct-centric pancreatitis, and tumefactive chronic pancreatitis. These are all different terminology which is used for the same entity. There are usually two types, type 1 and type 2. Type 1 is usually more common, type 2 is less, but it presents mostly in the younger group age. Type 1 mostly present with a jaundice, and type 2 usually present with acute pancreatitis in roughly one-third of the cases, followed by jaundice. Type 1 is more present in the male compared to females, rather it's equal distribution in the type 2. Recurrence is pretty common in type 1. IgG4 is usually elevated in type 1 rather than type 2. There are different serological markers which are always, most of the time, positive in type 1 rather than type 2. And there is an association with inflammatory bowel disease, but less common in type 1 rather than type 2 is relatively higher. And response to steroids is both equally common. As I said, relapse is also more common with the type 1. And extra pancreatic organ involvement is pretty common with the type 1. As I said, IgG4 is usually elevated. So IgG4 related diseases, systemic diseases are also very common in type 1. Usually in type 1, Usually in type 1 is also called lymphoplasmacytic sclerosing pancreatitis, and second one is idiopathic duct-centric pancreatitis, in which we don't find IgG cells, IgG4 positive cells. Both can lead to the storiform duct obliterative phlebitis with a more IgG4 in type 1, like more than 10, and no IgG4 cells were seen. But the epidemiology differs. Like in Japan, it's said that it's about 5 to 6% of the case. In the US, it's said that about 2 to 3%. But it was diagnosed in approximately 2 to 6% of the cases who underwent pancreatic resection for the suspected cases of pancreatic cancer. As I said in the beginning, it can present with the pancreatic mass also. As I said, type 1 is more common type 1 in females. The age distribution is for type 1 is more in the sixth decade, rather type 2 presents in the children or the earlier than 50 years of age. There are different predisposing factors like genetics, like autoimmunity. It is said that actually DRB1 and DQB1 are associated with the autoimmune pancreatitis. And DQB157 is more associated with disease relapse. Definitive autoantigen we don't know. Yes, there are some autoimmune marker which we do, and it was a very interesting thing. We used to say IgG4 associated, but it has been seen there are certain times we don't find IgG4 raised in these cases, especially in type 2. One of the human carbonic anhydrase type 2 and alpha carbonic anhydrase of Helicobacter pylori is associated. It is said that the autoimmunity is widely is the initial stimulus of type 2 helper T cells in immune response associated with autoimmune pancreatitis. Autoantibodies directed against the potential autoantibodies such as carbonic anhydrase, lactoferrin, tryptosinogen, pancreatic secretory trypsin inhibitor may also rise to the systemic inflammation of autoimmune pancreatitis. There are different environmental factors which can also triggers to the autoimmune pancreatitis, like intensive and prolonged exposure to solvents, industrial dust, oil, and polymers can lead to the initiation of autoimmune pancreatitis. Even one study cohort in England which showed blue collar workers like manual workers accounted for 61% of the patients with IgG4 related diseases, while only 22% were those from primary sclerosing cholangitis, which is a very close differential of IgG4 related disease, which indicates there are some environment factors, especially in particular group of agriculture, manual, and these particular type of blue collar workers are having more common. If you move on to symptomatology, what causes patient to come to you? The most common being is obstructive jaundice. being about 75% in type 1 and 66% in type 2, which can be with pancreatic and CBD involvement. And itself as acute pancreatitis in about 25 or 33% type 1 and type 2 respectively. It can also present like a pancreatic mass with no symptoms and extra pancreatic organ involvement. We'll briefly touch all of these. As acute presentation, it can present with acute pancreatic mass, obstructive jaundice, pancreatitis, and chronic or burnt out disease can present asymptomatic pancreatic mass. Penless chronic pancreatitis, steatorrhea with atrophic pancreas can also be the presentation. There are different extra pancreatic symptoms like sclerosing sialadenitis, involvement of the salivary duct, IgG4 related cholangitis, IgG4 related renal diseases, swelling of the lymph nodes like mediastinal lymphadenopathy. We find some hilar lymphadenopathy. Think of a TB, psychoid, but this can also be kept in differential and presents around 8 to 13% of the cases. Retroperitoneal fibrosis, chronic thyroiditis, prostatitis, inflammatory bowel disease up to 0.1 to 6% in type 1 and up to 16% in type 2 is associated with the autoimmune pancreatitis. So now we move on towards the diagnosis. How do we reach to the conclusion? It's not that well studied. So there are different criteria. The most commonly followed criteria is Hazard criteria, which follow up now. Like Hazard criteria, H stands for histology, I for imaging, S for serology, O for other organ involvement, and RT is a response to therapy. So we'll look into the histology first. This can present as periductal on histology on biopsy, periductal lymphoplasmacytic infiltrate, peculiar storiform fibrosis, which happens in the around the bile ducts, and obliterative venulitis by the plasma cells and lymphocytes. And there are usually abundant IgG4 positive cells, which is indicator of type 1. And this is also called GEL, granulocyte epithelial lesions. When we see the intraepithelial or the mucosal involvement with the neutrophils, that is called GEL, granulocyte epithelial lesions. This is one of the picture which we can see this involvement, and these are all IgG4 positive cells. Another artery is easily found, but vein is lost. But here we can say lymphoplasmacytic infiltration with fibrosis destroying the vein wall, resulting into the narrowing occlusion. This is called obliterative venulitis. The other one, which is type 2 usually, which is called idiopathic duct-centric pancreatitis. It also presents like a periductal lymphoplasmatic infiltrate, peculiar storiform fibrosis with none or very few IgG4 positive cells, less than 10. It's called GEL because intraluminal and intraepithelial neutrophils are seen. With medium size and ducts are involved, and destruction leads to the lumen obliteration. In type 2, we definitely need a biopsy to diagnose. However, type 1 can be diagnosed with other parameters also. This is a image of idiopathic duct-centric pancreatitis, which can heavy infiltration of the inflammatory cells, lymphoplasmacytic infiltration. It's inflammatory cells in the fibrosis, which leads to like these fibers. So the question is, although we know we can diagnose this particularly with the biopsy, but what to biopsy? The next question. Pancreatic biopsy, yes, we can do a EUS FNA, but not reliable as if we go for EUS related true cut biopsy, which has a better sensitivity and specificity. And third option is do a surgery for the pancreatic biopsy. The next option is if we can do the papillary biopsy. It is very specific, but sensitivity is not great. It's hard, one third, like 33% is the sensitivity. Another modality is intraductal bile duct biopsies, which is still debatable under research. And third thing, liver biopsy, but not usually necessary to go for it. This is one of the slide, like if you can see this papilla is edematous swollen papilla and the biopsy shows positive this IgG4 positive cells, about 50, which is a highly indicative of autoimmune pancreatitis and is also a part of extra organ involvement or extra pancreatic involvement. Now we move on to second part, which is called H or imaging, in which we have different modalities. We go for ultrasound, EUS, CT, MR, PET CT, ERCP, and MRCP. I'll go slowly through each of those. If you can see this image, this pancreas is very bulky, and this is called diffuse enlargement of pancreas with decreased ecotexture overall, or we call sausage-like appearance. It is typical of pancreatitis. It can be a diffuse form, as we saw just on the image, like diffuse pancreatic enlargement and chronic pancreatitis. You see reduced echogenicity, hyperechoic foci and strands we can see. There's also a focal form, as we in the beginnings we said it can present the mass. So solitary irregular hypoechoic mass can also be present. Upstream dilatation of main pancreatic duct, vascular invasion of portal vein or middle veins can be seen. Real-time tissue elastography can also be seen. We'll see these images one by one. If we can see, this is a diffuse pancreatic enlargement with echo-poor texture. Here we can see lobularity with the strands. This is also typical of autoimmune pancreatitis. This is a focal mass, focal lesion in the head with echo-poor hyperechoic strands also. FNA, as I said, has a sensitivity around 36% with a specificity 33%. However, if we go for true cut biopsy, it falls around sensitivity of 100% with a specificity around 100%. But the protocol is to FNAC followed by true cut biopsy if required. Next is to do a real-time tissue elastography in which we see the stiffness of that particular part. The higher it is, the green to the blue, it becomes hard, which is highly suggestive of autoimmune pancreatitis. There's a localized hypoechoic mass with a hypoechoic appearance, inclusion, also called like tortoise shell pattern here. And this is also duct penetrating lesion, as we can see. So next modality is the CT scan in autoimmune pancreatitis. As we said, like diffusely or locally enlarged pancreas can be seen with the mass. And they are typical pattern of, especially in the delayed images of the post-contrast CT, which is called capsule-like rim, which is highly specific towards autoimmune pancreatitis. If we can see, this is a swollen pancreas, which is diffusely swollen. Anybody can tell it's autoimmune pancreatitis. It's pancreatitis. But if you see the delayed images, the delayed enhancement of the itself keeps thick capsule around the pancreas, highly suggestive of autoimmune pancreatitis. Diffusely swollen pancreas with slow and delayed enhancement of the capsule-like rim around the pancreas. You can see. So these are same like CT is a gold standard for essential to look for the pancreatic malignancy and evidence of metastatic disease as the very close differential of IgG4 related disease or autoimmune pancreatitis is PSC and pancreatic malignancy. So gold standard being CT scan should always be done. Type 1 autoimmune hepatitis diffusely enlarged a sausage-shaped pancreas with loss of normal pancreatic clefts, delayed and peripheral rim of enhancement with character surrounding or hypoattenuating or low signal rim of halo on the CT scan. Minimally associated peripancreatic soft tissue stranding and rarely if inflammation of the mesentery in the autoimmune. Local peripancreatic lymphadenopathy can also be observed. Pancreatic calcification, cirrhosis formation usually not that common in autoimmune pancreatitis. And pancreatic duct is irregularly narrowed in affected segments. We'll see some images related to the pancreatic duct itself. Another modality is PET-CT, accumulation of FDG in pancreatic or extrapancreatic lesions which disappear shortly after steroid treatment. As we all know, PET-CT also takes the uptake wherever there is inflammation. So autoimmune pancreatitis also take the uptake. But the good and the beauty of our PET is we treat with the steroids. And one of the criteria for the autoimmune pancreatitis is the dramatic response to the steroids. All the inflammation goes away on the PET-CT as well. If we can see, these are different areas of involvement with FDG uptake. And if it's post-treatment, just 2 weeks of treatment, most of the uptake is gone compared to both images. There's a diffuse pancreatic involvement with increased FDG uptake in the enlarged pancreas. Another modality is the MRI. It can, similarly to MRI, it can delineate the diffusely enlarged pancreas or there is a capsule-like rim around the pancreas, which is highly specific for the autoimmune pancreatitis. If you can see these images, the thick capsule around the pancreas. So MRI shows diffuse or localized enlargement of the pancreas with lower density in T1 weighted images and higher density in T2 weighted images compared with each liver images. Generally, strictures associated with autoimmune disease are long, continuous, whereas multifocal short strictures are more typical of PSC, although differentiation can be very difficult at times. The next is the ERCP. How do we go for? There's different criteria on ERCP. Like these are key features, 4 features like long strictures, more than 1/3 of the pancreatic tract involvement, lack of upstream dilatation of less than 4 millimeters, multiple strictures, and the side branches arising from the strictured segment. You'll see the images gradually. If you can see, this is a feature one, like long stricture. This is feature two, which stenotic dilation is not that more than 5 millimeters. This is feature three, and this is feature four, the arising of duct from the narrowed segment. So these are also typical of autoimmune pancreatitis on ERCP. This is MRCP, which shows the same thing, but it is not one of the recommended thing to do in particularly for the autoimmune pancreatitis. Yes, it's very close differential and which can delineate the PAC itself. Now we move on to the another criteria, which like S, which is serology, and basically it's IgG4. Normally, the values range from 8 to 140. It's pathognomic, thought to be, but nowadays characteristic but not diagnostic of autoimmune pancreatitis. The sensitivity and specificity falls around 75 to 90%, 93%. Positive predictability is also relatively low and should ideally be more than 2 times of normal or upper limit of normal to be specific or highly specific. You can see if it is, we take this 140 or more, the sensitivity is around 76%, specificity of 93%, with positive predictive of 36%. If we move on to more than double, 280, it becomes 53% the sensitivity, specificity of 99%, and positive predictive also falls around 75%. So higher the value, the more in favor of autoimmune pancreatitis. Now we move on to the fourth criteria, which is this other organ involvement or extra pancreatic involvement. There are different organs which can be involved, like on examination, we can see salivary gland enlargement. On imaging, we can see proximal bile duct strictures, retroperitoneal fibrosis, renal or pulmonary lesions. And on histology, we see lymphoplasmacytic infiltrate, IgG4 positive cells, storiform fibrosis, and obliterative phlebitis, which as we saw in the type 1 in the beginning. These are some thickening of the bile duct. If we see this, like in the wall, which is thick, and usually if we can see, it becomes like thick wall, that much thick. It's typical of thickening, but there are differentials of this thickening of bile duct also, not just IgG4 related. If we can see this is a dilated bile duct with funnel shaped, it is also more in favor of autoimmune pancreatitis or autoimmune or IgG4 related cholangitis. If you can see, this is the like sandwich-like appearance between the duct. So what are the differential if we look for the thickening of the bile duct? One includes the cholangitis, which means diffuse involvement of the bile duct would be there. And if we see PSC, it will be asymmetric, and secondary sclerosing cholangitis like IgG4 related cholangitis, it also will be asymmetric. Autoimmune pancreatitis has common bile duct involvement. If you can see, this is the strictured area with the distal CVD, which is also most commonly found in terms of autoimmune pancreatitis or IgG4 related cholangitis. There are different cholangiographic features of PSC and autoimmune pancreatitis. Like if you can see, there's a multiple focal strictures with beaded appearance and intermittent dilatations also in PSC. But relatively in autoimmune pancreatitis, you see long strictures with long strictures compared to that, and there's no beading as appearance as usually see in that PSC. It is said that in all patients with possible PSC, it's suggested to do measure IgG4 levels to exclude IgG4 related sclerosing cholangitis. Relatively, its response is much better in terms of IgG4 cholangitis compared to PSC itself. And there's also extrapancreatic the involvement, as we saw this slide earlier, the involvement of papilla in the biopsy is also highly specific, almost 100% if you take a biopsy sample from the papilla or ampulla. This CT is suggestive of like diffusely swollen pancreas, the same CT, same person, and involvement of bilateral parapelvic lesions. Even this lesion on the left peripelvic or perirenal regions. This retroperitoneal fibrosis around the aorta. This multiple lesions in the kidneys. So now we move on to the third criteria, which is very important nowadays and bit also controversial in terms because people, if you have suspected pancreatic cancer treatment, you are giving steroid trial, so you are missing the time. If you are having the autoimmune pancreatitis with the presentation of mass, you are going for surgery, which would have been considered as unnecessary if it is proven earlier ahead. So there is a mass in the body of the pancreas, which we can see. And after the treatment, the mass is gone. We can compare both. And in the second image, if you can see, there is a stricture and highly, like we cannot see well this the long stricture on this image. But however, after treatment, it's almost gone. The pancreatic is almost normal here. So that's the reason in all PSC cases, IgG4 should always be checked. It's potentially treatable disease. And this is also the before treatment because in the stricture here and the stricture is gone here. Then subsequent after treatment. The lesion in the pulmonary lesion, which has also disappeared after the treatment, after steroid therapy. But caution always is there with behind the steroid trial, like not to be used as a substitute for thorough search for the other etiologies, not to be used if any objective way of to define the response. Just do the steroid trial and we'll look into it. So there are challenges to diagnose the autoimmune pancreatitis because it closely mimics a pancreatic cancer and primary sclerosing cholangitis. So there should be high index of suspicion of other disorders. And it is rare relatively to the pancreatic cancer, roughly 2 to 3% of the patient with suspected pancreatic cancer. So it's still there are 70% of the patients who will have pancreatic cancer. And unfortunately, there's not a single test to diagnose it. It's a criteria, different criteria. And if you misdiagnose it, it's a heavy price for it. So we move on to treatment. How do we manage such cases? What should be the next done? And it's the fifth and last criteria also, the treatment, the responsive treatment. 99% of the type 1 autoimmune pancreatitis and 92% of type 2 autoimmune pancreatitis patients went into clinical remission with steroid therapy itself. It's a very remarkable thing in terms of this. So how do we measure that steroid therapy is working or no? How do we see? So it's into remission or no? There's a criteria like symptom A, B, and C. C is radiotherapy or sorry, not radiotherapy. The radiology, S is serology, and S is symptoms. So S is A, B, C. Resolution of all the symptoms A. Normalization of IgG4 or IgG4 level and resolution of pancreatic enlargement or main pancreatic narrowing. Histology is back to normal, and function of the endocrine or exocrine function of pancreas should go back to normal. So these are the criteria or for the remission. And treatment outcome is complete remission or incomplete. Means when you achieve A, B, and C, means symptom, serology, and radiology all are normal. This is called complete remission. If two of those are achieved, that means it's incomplete remission. And when do we call relapse? When the symptoms come back, serology becomes high, radiology shows the same features again, histology also is consistent with autoimmune pancreatitis. This is called relapse. So this is a way to go for the treatment. Like you start at a high dose of steroid, usually it's 0.6 to 1 milligram per kg body weight, and then followed by if response is there, complete withdrawal of steroids, or you can go on a maintenance, slowly taper it off in 2 months' time. If it is off period, off steroids, sustained remission is there, we can stop the treatment. And if the relapse is there, we have to consider either we go for the rituximab for the refractory cases or restart the steroids followed by immunomodular therapy like azathioprine, 6-mercaptopurine. This is the treatment of relapse actually. If the patient has to be treated, went well, but he came back with the recurrence of symptoms, imaging, and the biopsy finding. So if we see, we start again with the steroids 40 milligram in normal person or 0.6 to 1 milligram per kg weight, body weight. If it is diabetic, we go for the lower dose, like 30 milligram of steroids. We reassess the activity at 6 to 8 weeks time. If the patient is steroid intolerance, relapse is there, we can go to the rituximab. The patient is tolerant and response is very good, we can continue with the tapering dosages and followed by maintenance therapy. If patient is not responding or there is incomplete response or you cannot reduce the steroid dose more than 20 milligram, you have to keep those more than, then you can consider for rituximab also. And definitely whoever is non-responder to the immunomodulator relapse further is also a candidate for rituximab. Generally, prognosis is very good, but even may progress to chronic pancreatitis within months if not treated with steroids. And glucocorticoids may even reduce the symptoms and reverse of emerging imaging abnormality which we have seen. This is briefly about the same finding which we had discussed with type 1 and type 2. The type 1 is relatively more common. Both are easier to treat. Type 1 is comes in the sixth decade, while type 2 is common in the younger age group, less than 50 years of age. And treatment response is essentially the same. And if we see the IgG levels, even on the IgG cells, positive cells on biopsy are more common in type 1 and less on the type 2. These are my references. Thank you.